Ya, terima kasih banyak Bapak Ibu sekalian atas kehadirannya pagi ini dalam acara seminar pagi hari ini. Bapak Asep, terima kasih banyak atas kesempatan yang diberikan kepada kami untuk berdasarkan hasil penelitian ini. Dan ini merupakan studi bersama kami antara dengan Pak Jeffrey Sine dan juga dari RKI Internasional dan juga dengan Firman Witular dan dari Alpha dari Suplementer. Dan ini bisa kita lakukan dengan support dari data yang dikumpulkan pada saat studi dengan pada saat USA kinerja proyek yang dari Papua. Terima kasih sekali untuk pihak USA kinerja Papua atas data yang sangat-sangat kaya ini. Terima kasih sekali. Nah, presentasi pagi ini akan kita bagi menjadi 4 bagian. Artinya ada 4 subtopik yang kita akan bahas. Yang pertama terkait dengan studi konteksnya seperti apa, kemudian terkait dengan sampel dan metodologi yang kita pergunakan, kemudian hasilnya, dan terakhir kita akan membahas tentang bagaimana penggunaan dari hasil ini dan kemudian implikasi daripada hasil dari studi yang kita lakukan ini. Nah, pertama tentang konteks dari studi ini. Jadi studi ini seperti saya bilang tadi bahwa menggunakan data yang kita kumpulkan untuk terkait dengan proyek USAID Gereja Papua, di mana USAID Gereja Papua Project itu tujuan utamanya adalah bagaimana memperbaiki kualitas dari pelayanan kesehatan nasional lewat perbaikan dari inovasi daripada pengelolaan tata kelola pada sektor manajemen, misalnya terkait dengan manajemen daripada pelayanan kesehatan yang ada di Papua. Nah, seperti diketahui kemudian absenteeism ini adalah salah satu faktor yang kemudian diketahui sangat mempengaruhi kualitas daripada pelayanan pemberian layanan kesehatan yang ada dimanapun, bukan cuma di Papua tapi di berbagai belahan dunia ini. Nah, untuk melakukan intervensi untuk mengurangi tingkat absenteeism ini, maka kita perlu mengetahui dulu apa sih akar permasalahan yang menyebabkan kemudian absenteeism ini terjadi. Nah, ini oleh karena itu kita lakukan studi ini dilakukan di 4 kabupaten kota yang ada di Papua yang melakukan gelar kerja dari USAID Kinerja Papua, yaitu satu di Kabupaten Jayapura, kemudian Kota Jayapura, Kabupaten Mimika, dan Kabupaten Jaya. Nah, hasil ini kemudian, dari hasil itu kita mengetahui ya apakah kemudian penyebab daripada absenteeism ini adalah sama antara setiap kabupaten kota ini atau mungkin berbeda. Nah, kalau berbeda tentunya kita perlu mendesain kemudian intervensinya berbeda juga untuk setiap kabupaten dan kota. Nah, apa yang kemudian kita hasil dari studi ini kemudian dipergunakan untuk memformulasikan sebuah intervensi lewat kemudian kita adakan dialog dengan pemangku kepentingan. Kita sampaikan hasil ini kepada pemangku kepentingan, kemudian pemangku kepentingan berdiskusi. Kita membahas kinerja Papua, kinerja Papua, kemudian memfasilitasi kemudian diskusi itu untuk memformulasikan kemudian yang apa yang kita sebutkan operational policy barrier analysis. Apa kemudian desain intervensi yang kami lakukan berdasarkan hasil temuan yang dari studi ini. Nah, studi ini kita lakukan tahun lalu pada bulan Mei sampai dengan bulan Juni tahun 2014. Nah, secara garis besarnya, secara umum ini studi ini mempunyai 4 tujuan. Yang pertama ingin mengetahui kemudian tingkat rate daripada absenteeism yang ada oleh petugas kesehatan untuk 3 kategori. Pertama adalah dokter, kemudian yang kedua adalah perawat dan juga bidan. Yang kedua tujuannya adalah untuk mengetahui perspektif daripada absenteeism dari sisi petugas kesehatan. Bukan itu aja, tapi kita juga perlu melihat bagaimana kemudian dari sisi persepsi daripada kepala puskesmas, health center ini, bagaimana persepsinya dia. Dan berikutnya kita bukan cuma berhenti dari sisi pelayanan kesehatan dari sisi supply-nya, tapi kita juga lihat dari bagaimana persepsi dari pengguna dari fasilitas kesehatan tersebut. Dalam hal ini adalah anggota masyarakat dan juga tokoh masyarakat. Kita lakukan juga. Jadi ini mendapat informasi persepsi daripada bukan cuma absenteeism tapi juga bagaimana terkait dengan pelayanan yang diberikan oleh Puskesmas. Yang terakhir kemudian tujuannya adalah menggunakan evidence ini, data hasil penelitian ini untuk memformulasikan operational policy atau intervensi yang dilakukan untuk mengurangi absenteeism itu sendiri. Nah, konsep framework yang kita pergunakan untuk studi ini adalah seperti terlihat di dalam gambar sini, bahwa ada 4 komponen yang mempengaruhi kemudian tingkat ketidakhadiran. Ya. Salah satunya adalah komponen pertama adalah terkait dengan karakteristik daripada individu itu sendiri. Yang kedua adalah bagaimana lingkungan daripada di sekitar daripada Puskesmas itu sendiri dan juga lingkungan daripada di mana dia tinggal, si petugas kesehatan sendiri. Yang ketiga adalah karakteristik daripada fasilitas kesehatan sendiri dalam hal ini keadaan dari Puskesmas itu sendiri. Yang terakhir adalah juga yang menentukan adalah bagaimana kemudian lingkungan daripada kebijakan, artinya institutional policy dan gimana keadaannya sendiri. Secara institusi seperti apa di sini. Nah ini yang kita coba lihat. Nah, sampel frame daripada studi ini adalah semua Puskesmas yang ada di 4 kabupaten kota ini. Yang jumlah totalnya keseluruhan itu ada 57 Puskesmas yang ada di 4 kabupaten kota ini. Tapi yang kita masukkan dalam studi adalah hanya 50 karena 3 diantaranya kita pergunakan untuk pilot, ya, karena kita mesti melakukan pilotnya juga. 3 itu kabupaten Puskesmas yang ada di Kabupaten Jayapura kita gunakan untuk pilot. Jadi 1 perwakilan yang dari kota, 1 perwakilan yang tengah-tengah, 1 lagi yang cukup jauh remote dari kota, dari remote lokasinya. Kemudian ada 4 Puskesmas yang ada di Kabupaten Mimika yang kita nggak masukkan dalam studi ini karena kemudian sangat-sangat terpencil sekali. Kalau pergi mencapainya kita mesti menyewa helikopter, biayanya mahal sekali. Kemudian belum nyisian kita diputuskan pada saat diskusi kita nggak masukkan dan juga sudah ada perwakilannya dari beberapa tempat yang lainnya. Jadi sehingga kita akan pada saat studi ini mengunjungi 50 dalam studi ini adalah 50 Puskesmas yang kita wawancarai. Kemudian untuk petugas kesehatannya kita memulai dengan mendapatkan daftar dari petugas kesehatan yang ada di Puskesmas yang kita akan target kita itu dari dinas kabupaten kota, dari kabupaten kota, dari dinas kesehatan kabupaten kota. Jadi listnya kita dari sana. Karena kita turun bulan Mei, jadi itulah versi yang bulan April kita peroleh dari kabupaten kota. Kemudian dari daftar ini, dari daftar yang kita dapatkan dari dinas kesehatan kabupaten kota, kemudian kita lakukan verifikasi konfirmasi pada saat kunjungan pertama kita ke Puskesmas, kemudian kita konfirmasi secara verbal. Apakah kemudian kita cek lagi orang-orang ini masih ada nggak, petugas kesehatan ini masih ada di situ dan juga hadir apa tidaknya. Kemudian untuk pada tingkat komunitas ini adalah kita lakukan 100 fokus grup diskusi, yaitu 50 diantaranya fokus grup diskusi untuk laki-laki, masyarakat laki-laki, dan 50 lagi adalah yang perempuan. Jadi 1 Puskesmas ada 2 fokus grup diskusi, 1 untuk laki-laki dan 1 untuk perempuan. Dan kita juga melakukan wawancara mendalam untuk tokoh masyarakat. Hanya untuk presentasi pagi ini kita tidak menggunakan informasi dari komunitas ini, tidak menggunakan data dari kualitatif tadi ini, tapi sebenarnya sangat kaya sekali. Kami juga ingin informasi sangat kaya sekali dan benar-benar jernih sekali. Jadi perspektifnya pandangannya beda sekali dengan apa yang kita peroleh dari sisi kemudian petugas kesehatan ataupun kepala Puskesmas yang ada di sana. Ini sangat kaya sekali. Nah, inilah detail daripada sampel kita untuk petugas kesehatan. Nah, jadi kita pergi ke 50 Puskesmas yang ada di 4 kabupaten kota tersebut. Nah, yang kita wawancarai adalah untuk dokternya, kita lakukan sensus, kita wawancarai semuanya, baik yang hadir maupun tidak hadir pada saat kita kunjungan pertama. Demikian juga untuk bidangnya, kita lakukan sensus, kita wawancarai semuanya yang ada di 50 kabupaten kota tersebut. Yang kita kemudian lakukan sampling hanya untuk yang perawatnya. Yang perawatnya kita lakukan sampling secara random, yaitu untuk yang petugas yang hadir pada saat kunjungan pertama kita, itu kita yang tidak kita announce ya, kita tidak umumkan, itu adalah 2 per puskesmas. Kemudian untuk yang tidak hadir, yang absen pada saat itu, pada saat kunjungan yang tidak kita beritahukan itu 2 juga. Kemudian yang untuk ada juga sejumlah perawat yang pada saat kita berkunjung itu mereka ini sedang ada sip yang tidak dalam tugas pada saat itu, atau sedang bertugas melakukan pelayanan ke posyandu misalnya untuk yang di wilayahnya puskesmas. Nah seperti itu kita lakukan sensus untuk mereka. Kita mereka nggak hadir pada saat itu, tapi kita lakukan sensus, kita bagi dari 3 bagian. Nah, saya lupa menekan tadi bahwa untuk mereka-mereka yang tidak hadir pada saat kunjungan pertama itu, yang pada saat kunjungan kita pertama, kita lakukan men-tracking mereka. Kita mewawancarai mereka di rumahnya ataupun kita berkunjung lagi ke hari pada waktu lain kalau mereka kita buat janji kapan kita bisa lakukan wawancara untuk mereka-mereka yang tidak kemudian bisa kita yang tidak hadir pada saat kunjungan pertama tersebut. Nah, completion rate-nya itu adalah yang tertinggi adalah untuk yang bidan, yaitu mencapai 98%. Yang untuk perawat yang hadir itu 98%. Kemudian yang kedua adalah untuk yang bidan secara keseluruhan. Jadi kita kelompokkan, maksudnya kita jadikan satu karena sensus, kemudian baik yang hadir maupun tidak hadir totalnya itu sekitar mencapai 97% ya completion rate-nya dari target kita. Kemudian untuk dokternya itu mencapai 93%. Sedangkan yang terendah itu adalah untuk perawat yang tidak hadir dan juga yang kemudian pada saat kita kunjungan tidak hadir tapi sedang melakukan tugas pelayanan di luar puskesmas, misalnya ke posyandu dan lain sebagainya. Nah itu mencapai sekitar 87 sampai dengan 88%. Nah ini perbedaan rate antar kelompok ini ditentukan karena proses yang tadi itu untuk menemukan mereka-mereka yang absen tidak hadir pada saat kunjungan pertama itu cukup sulit. Walaupun kita sudah paling tidak teman-teman pewawancaranya udah mengkontak mereka, mencoba mengkontak yang target kita untuk yang tidak hadir pada saat absen pada saat kita berkunjung itu adalah sudah lebih daripada 3-4 kali. Dan kita juga melakukan proses trackingnya. Kadang-kadang mereka juga ada di luar kota cukup lama, misalnya di luar Jayapura kadang-kadang. Misalnya sudah mencuti untuk melahirkan di Makassar atau di luar provinsi sudah itu contohnya. Nah, untuk instrumennya kita punya 3 level instrumen. Yang pertama untuk pada level puskesmas. Pada level puskesmas ini mengumpulkan informasi dan untuk roster. Jadi daftar singkat keadaan daripada semua petugas kesehatan yang ada di puskesmas ini. Jadi kita kumpulkan informasi terkait dengan karakteristik daripada petugas kesehatan sendiri. Yaitu kita kumpulkan informasinya, salah satunya adalah terkait apakah hadir pada saat kita berkunjung pertama kali. Jadi ini adalah untuk roster ini kita tidak memberi informasikan kepada puskesmas bahwa kita akan hadir pada waktu itu. Ya. Kita nggak diinformasikan mereka. Kita administrasikan roster ini pada jam 9.30 sampai 10.30 di antara jam tersebut. Dari hasil pilot kita, kalau kita lakukan sebelum jam 9.30 itu banyak yang petugas kesehatan belum hadir. Nah kalau kita lakukan jam 8 itu bisa semuanya nanti 100% gitu, karena belum ada, baru pintunya aja yang dibuka sebenarnya. Semua belum ada yang membuka pintunya itu adalah driver daripada ambulannya, soalnya kemudian yang lain-lain belum ada. Jadi kita kalau kayak gini 100% semua jadinya yang tidak hadir. Kemudian di satu tempat kita datang lebih awal, satu tempat lagi kita datangnya memang bukan sebenarnya kita nggak bermaksud demikian seperti itu, tapi kemudian karena kita baru selesainya sudah sempat di satu puskesmas itu siang sekali, jadi kita pergi satu puskesmas yang lain itu udah pada pulang semuanya kan, seperti itu. Hampir 90% udah mulai pulang, jadi setelah jam 10.30 gitu. Jadi udah hampir semuanya pimpinan, jadi nggak mungkin kita lakukan kalau misalnya kita tidak tentukan waktunya, jadi tidak tentukan waktu kunjungnya untuk roster ini untuk mengetahui apakah hadir tidak hadirnya, akan sangat membingungkan sekali nanti kalau terlalu puskesmas di satu tempat kita kunjungin awal sekali dari ini, kemudian kalau pas terlalu terlambat setelah jam 10.30 akan jadi berabe juga, nanti kita akan bertengkar hanya karena masalah waktu kunjungan yang berbeda-beda untuk setiap puskesmas. Jadi hanya terputuskan bahwa ini adalah mengetahui hadir tidak hadirnya adalah pada periode waktu jam 9.30 sampai dengan jam 10.30 gitu. Pada kunjungan pertama ini benar-benar kalau mereka lebih awal datangnya, mereka akan belum wawancarai tugas atau wawancaranya seperti itu. Jadi belum mereka akan wawancarai roster ini seperti itu. Jadi mereka akan nunggu dulu sampai jam 9.30 sampai dengan 9.30 di antara waktu itu. Nah inilah waktu yang kita melihatnya bahwa pada saat itu petugas kesehatannya, petugas dari puskesmas ini ada hampir semuanya seperti itu ya, udah ada pada saat itu memberikan pelayanan. Nah ini kan kita tanyakan untuk konfirmasinya bukan langsung kita berarti ke ke kepala puskesmas. Nah untuk pada tingkat puskesmas ini kita kumpulkan informasi juga tentang detail tentang karakteristik daripada kepala puskesmasnya. Jadi kita punya khusus untuk terkait dengan kepala puskesmasnya. Bukan cuma sekedar demografinya, pendidikannya, tapi juga kita tanyakan persepsinya dia tentang bagaimana kemudian tingkat daripada absenteeism di puskesmasnya dan hal-hal lain tentang intervensi apa yang mereka lakukan dan sebagainya. Kemudian kita juga mengumpulkan informasi melakukan asesmen tentang keadaan daripada puskesmas itu sendiri pada level puskesmas. Kemudian yang level kedua kita mempunyai informasi untuk petugas kesehatan itu sendiri. Jadi kita tidak hanya memiliki yang roster itu, tapi kita memiliki data yang lebih yang lebih detail tentang puskesmas petugas kesehatan yang tadi yang hadir maupun tidak hadir. Ya. Jadi kalau yang dokter kita sensus ya kita dan juga bidan dan sensus kita punya informasi individu dari setiap petugas kesehatan yang dokter dan tentu yang hadir tadi ya, yang dokter dan juga bidan. Tapi untuk yang perawatnya kita punya tadi sampling, jadi 2 untuk yang hadir dan 2 lagi yang tidak hadir, dan kemudian yang sedangkan yang kalau sedang melakukan tugas di posyandu tempat lain kita lakukan sensus. Nah ini kita mempunyai informasi yang lebih detailnya. Ini data informasi inilah kita pergunakan nanti dalam studi dalam paper kita. Kemudian pada level komunitas kita punya instrumen untuk fokus grup diskusinya dan juga untuk interview. Nah, dengan data yang kita kumpulkan ini kita mempunyai kesempatan untuk mengukur tingkat absenteeism ini untuk dua keadaan. Yang pertama adalah terkait yang disebut dengan cross-sectional absenteeism. Ini adalah dari informasi kunjungan kita pertama kali tadi. Kunjungan kita ke puskesmas ini pertama kali yang kita tidak umumkan itu. Ya. Dan inilah kita lakukan, kita seperti saya katakan tadi bahwa kita dapatkan list dari dinas kabupaten kota, dinas kesehatan kabupaten dan kota, kemudian kita konfirmasi, kita tanyakan kepada kepala puskesmas atau yang senior yang mewakili di situ. Kemudian kita tidak hanya percaya kepada informasi dari kepala puskesmas saja tentang siapa yang hadir dan hadirnya pada saat itu, tapi kita juga melakukan observasi langsung dengan langsung juga mendatangi ruangan-ruangan dari petugas kesehatan itu. Ketemu yang siapa namanya bidan A seperti itu, kita lihat bidan A itu yang mana ya seperti itu. Jadi kita punya ada kolom variabel yang mencatatkan kemudian hasil observasi kita ini. Sehingga yang kita pergunakan lah untuk hitung absenteeism itu dari hasil observasi kita. Jadi kita punya persepsi dari informasi yang dari pengetahuan ataupun informasi pernyataan dari kepala puskesmas ataupun yang wakilnya. Tapi yang kita pergunakan adalah yang kita dalam analisis ini adalah yang dari observasi kita, belum ada atau tidaknya. Kadang-kadang ada beberapa hal kemudian petugas kesehatannya sebenarnya nggak ada tapi dibilang ada. Nah, Nah kemudian ini kita punya untuk semua petugas kesehatan yang ada di puskesmas tersebut. Nah kemudian yang kedua kita juga bisa mengukur kemudian dengan self-reported historical dari absenteeism ini. Itu selama 4 minggu terakhir, ya, dari yang kita dapatkan dari wawancara langsung dengan petugas kesehatan yang tadi itu, yang baik yang hadir maupun tidak hadir. Dan kita bisa melakukan juga dengan ini. Ya, jadi kita dapatkan dari interview langsung kita dengan petugas kesehatan. Tapi untuk sekarang ini kita akan menggunakan data yang cross-sectional untuk paper kita. Nah, kemudian untuk presentasi pagi ini kita melakukan untuk mendapatkan kemudian correlate apa-apa faktor-faktor yang mempengaruhi kemudian absenteeism di distrik ini, interdistrik korelasi ini, korelasi seperti apa? Kita melakukan regresi logistik. Nah, dengan dependent variabelnya adalah kemudian hadir dan hadir, yang cross-sectional tadi. Satu hadir dan yang nol tidak hadir. Nah, kemudian kalau independent variabelnya kita menggunakan tiga kelompok dimensi yang mempengaruhi absenteeism ini. Kita tidak menggunakan satunya lagi yang terkait dengan policy dan lingkungan dari kelembagaan ini, tapi tidak masukkan faktor ini ke dalam logistik kita, tapi kita pergunakan nantinya adalah sebagai masukan pada saat melakukan diskusi kepada stakeholder untuk menentukan pada saat membuat desain untuk intervensinya, dan kita masukkan yang kita sebutkan dengan operational policy barrier analysis. Nah, ini kita masukkan di sana komponen yang keempatnya terkait dengan kelembagaan atau terkait dengan lingkungan kelembagaan maupun policy. Nah, kita masukkan dari situ nantinya. Jika di sini lebih 3, tapi kita masukkan di aspek pada saat kemudian kita melakukan analisis bersama-sama untuk intervensinya. Nah, untuk setiap kelompok dimensi dari faktor yang mempengaruhi ini, kita memilih sejumlah kemudian dari review, kemudian dari diskusi dengan pengambil kepentingan di awal studi ini juga, kemudian dari pengamatan kita juga bahwa kita memilih sejumlah variabel untuk setiap kelompok ini. Pertama kali terkait dengan karakteristik dari individu itu, kita masukkan kemudian informasi terkait dengan gender, kemudian profesinya seperti apa, sebagai apa, dokter ataupun perawat ataupun bidan seperti itu. Kemudian terkait dengan status perkawinannya, sudah menikah atau tidak, kemudian umurnya kita masukkan juga. Ini kemudian kita memasukkan juga apakah bagaimana kemudian kalau kondisinya, kalau petugas kesehatan itu mempunyai anak di bawah 6 tahun, seperti itu, seperti apa. Kemudian pengalamannya dia bekerja sebagai petugas kesehatan. Dan yang terakhir kita masukkan juga adalah etnik etnik dan campuran dengan tempat lahir daripada petugas kesehatan ini. Jadi kita memperhatikan etniknya dari apakah Papua non Papua, tapi juga kita perhatikan bukan cuma Papua non Papua, tapi juga kita perhatikan adalah tempat lahirnya. Kalau misalnya Papua, tapi kemudian apakah lahir di sana atau non Papua, tapi lahirnya di Papua, seperti itu. Nanti akan kita hasil seperti apa aja. Kemudian dari kelompok dari karakteristik daripada lingkungannya ini menyangkut juga biaya untuk pergi ke kita masukkan variabel biaya untuk pergi ke fasilitas kesehatan tersebut, ke puskesmas ini berapa. Kemudian terkait dengan perumahannya, apa terkait dengan rumahnya, apakah tinggal di puskesmas perumahan yang disediakan oleh puskesmas atau di luar puskesmas, tinggal di luar fasilitas perumahan puskesmas. Yang berikutnya juga kita perhatikan juga apakah kemudian tinggal dengan keluarga enggak si petugas kesehatan ini, kita masukkan kepada dengan lingkungan. Kemudian dia memiliki enggak kemudian praktek mandiri di luar bertugas di fasilitas puskesmas ini. Dan kita juga mengumpulkan beberapa informasi yang kita pikir mempengaruhi, di antaranya apakah dia ingin bermaksud untuk ingin pindah nggak dari lokasi tersebut. Kita masukkan juga bagaimana kepuasannya dia bekerja di fasilitas itu, kita kumpulkan kita masukkan sebagai salah satu juga variabel yang kita masukkan dalam karakteristik daripada lingkungan. Dan terakhirlah kita memasukkan juga kemudian komposisi etnik daripada komunitas yang dilayani oleh petugas kesehatan itu. Apakah kemudian komposisinya adalah Papuan semuanya itu bagian Papua atau bukan Papua atau mix sebenarnya. Nah ini kita masukkan juga sebagai satu kriteria yang kita masukkan dalam kelompok lingkungan kasih lingkungannya. Dan terakhir untuk kelompok yang keadaan puskesmas, kita masukkan cukup banyak variabel yang kemudian kita lihat apakah kemudian mempengaruhi nggak kemudian ketidakhadiran dari petugas kesehatan. Di antaranya apakah puskesmas ini bukan puskesmas ponet atau tidak, apakah puskesmas rawat inap atau tidak, kemudian bagaimana waktu berapa hari waktu bukanya dalam 1 minggu, apakah 7 hari atau kurang, kemudian jumlah dari desa yang dicakup oleh puskesmas ini untuk dalam jangkauannya, kemudian bagaimana kemudian kondisi dari fasilitas kesehatan ini kita juga masukkan sebagai sebuah indeks, sebagai sebuah satu independent variable kita. Selanjutnya kita juga lihat bagaimana kemudian kondisi daripada komunikasi dari jaringan komunikasi di wilayah tersebut, diantaranya adalah akses internet dan juga untuk sinyal telepon. Dan paling yang menarik juga dalam yang kita masukkan dalam studi ini adalah karakteristik daripada kemudian kepala puskesmasnya. Karakteristiknya seperti apa? Apakah mempengaruhi nggak ketidakhadiran daripada puskesmas? Ketidakhadiran dari petugas kesehatannya. Kita masukkan sebagai karakteristik daripada puskesmasnya. Yang berikutnya kita juga masukkan dalam pertanyaan kita tanyakan apakah ada upaya-upaya nggak yang telah dilakukan oleh puskesmas masing-masing untuk mengurangi ketidakhadiran. Jadi kita masukkan sebuah indikator di sini ya, untuk yang mungkin mempengaruhi ketidakhadiran. Dan terakhir kita masukkan juga adalah supervisi yang dilakukan oleh dinas kesehatan kabupaten kota. Apakah mengambil ketidakhadiran? Kita melihat seperti itu. Nah, sebelum kita masuki hasil daripada logistik regressionnya, saya ingin menampilkan inilah tingkat dari ketidakhadiran. Kalau kita lihat berdasarkan kabupaten kotanya, di sini terlihat sekali bahwa ada gap yang luar biasa antara setiap kabupaten kota. Yang paling tinggi itu adalah di Kabupaten Jayapura, yang paling rendah di kota Jayapura seperti kita duga. Banyak yang kaget kemudian kenapa di Kabupaten Jayapura yang paling tinggi ya. Kemudian yang berikutnya adalah di yang kedua tertinggi itulah di Kabupaten Mimika, dan yang ketiga itulah Jaya. Ya. Pada tingkatnya untuk setiap kabupaten itu berbeda-beda, dan ini juga kita duga juga sebelumnya adalah kemudian bisa direka-reka pasti juga penyebab untuk ketidakhadiran untuk setiap kabupaten kota, baik yang rendah maupun yang tinggi ini juga pasti berbeda-beda juga kita. Atau mungkin ada yang sama, tapi juga ada sumber yang berbeda. Nah kalau berbeda-beda, ini artinya bahwa kebijakan yang diambil untuk menurunkan tingkat absenteeism ini pun mesti berbeda-beda untuk tiga kabupaten kota. Ya, barangkali tadi malah kita berdiskusi barangkali juga di setiap kabupaten kota juga kalau kita mau ke bawah lagi mungkin juga berbeda-beda. Kita bisa melihat itu karena memang banyak sekali faktor-faktor lain yang sebenarnya sangat sulit. Tapi yang jelas yang kita lihat pada saat sekarang ini adalah bagaimana kemudian interdistrik daripada korelasi yang berbeda. Ya, apakah bagaimana korelasi untuk setiap distrik ini? Untuk sebagian saya akan berdiri di sini, saya akan serahkan ke Pak Asep untuk bisa menerangkan bagaimana kemudian dua bagian berikutnya hasil daripada analisis logistiknya dan juga bagaimana penggunaan daripada hasil tersebut untuk mengambil kebijakan. Pak Asep, silakan.
Is it working? Yes. It's working. Okay, if I wanted to present in Bahasa Indonesia, I would have had to spend a lot more time preparing for that to do it, but it will be much more clear in English. If anything is not clear, please feel free to ask any questions, stop me. It gets a little bit difficult to follow, perhaps it's actually been difficult to explain. But as Wayan has already so well explained, we can already guess from this large variation in inter-district variation in absenteeism rates that the drivers or the correlates of absenteeism probably are quite different in each kabupaten and kota here. So that's what we sought to explore. And again, keeping in mind the purpose of this was a very policy-oriented purpose to identify workable interventions that would help to reduce absenteeism in these districts. If you, and I should say that we also did a logistic regression pooling across all four districts. And the results were quite different. And one of the reasons is because one variable might be significantly important in one district, but completely unimportant in another. When you put all the districts together in one model, it comes out as perhaps not significant. Or one district would have a variable where the impact of that variable was positive, and another was negative. And the average of the two shows that variable not to be important, so you might miss some important opportunities to influence absenteeism if you looked at it with just the pool data across the province. So we're going to take a look at some of those differences now. Let's see if I can. Great. Okay. All right. So we're going to follow the framework that Wayan just explained to us, the three categories: worker characteristics, the environmental characteristics that the health worker finds her or himself in, and the characteristics of the Puskesmas. Now we included the health center head variables as a Puskesmas characteristic as well. You might have thought about putting them in environment, but we defined environment as beyond the Puskesmas. Looking at the worker characteristics first, a dot, let's see, does this have a pointer? Yes, okay. A dot such as these means that the variable in that district was not significant. We're not presenting the pooled regression results. We have them if anybody's interested, but I don't think they're very meaningful for reasons I just stated. Where there's 1+, such as here, that means the variable was significant in that district at the 0.1 level. So some might call that important but not significant. Where if there are 2 pluses, it was significant at the 0.05 level, and 3 pluses means it was significant at the 0.01 level. One other thing I should point out, as we go through this, I'll explain which ones. Seeing 3 pluses doesn't mean it was associated with higher absenteeism, but I'll get into that detail. I have my little cheat sheet here that I'll be referring to. Okay, so as we can see, male health workers are not significantly more or less absent than female health workers. So what does it say? It says don't target gender as a characteristic around which to design an intervention. It's not going to have any differential effect. We look at profession. It was not important. Doctors, nurses, and midwives in these 3 districts were neither more or less likely to be absent than the other profession, except in Jaya, where it was significant, and the nurses were twice as likely to be absent as midwives and doctors. So the implication there is if the district health office wanted to target an intervention in Jaya, they might focus on trying to understand why nurses are more likely to be absent than doctors and midwives, and design an intervention that addressed those reasons, or the policy barriers, operational policy barriers to nurses having a better attendance record. Age was important in 2 of the 4 districts, not in 2 of the others. An interesting aspect is that in Kota Jayapura, it's the older workers, those above age 40, who were more likely to be absent. Whereas in Kabupaten Jayapura, it was the younger workers, 20 to 29, who were more likely to be absent. So again, you wouldn't target age the same. In 2 of the 4 districts, you would target age potentially as an intervention to address absenteeism, but you have to look below just the age variable and understand that there are inter-district differences in how age plays out as an explanatory factor of absenteeism. Being married, was a significant driver of absenteeism, again, in these two districts, not the other two. Being married carried a higher likelihood of being absent than being single. So we decided that the intervention should be don't allow people to marry. Try only single people. Nobody liked that idea. Having children under 6 years of age, our rationale for including that was we thought that, particularly for women who, still in most societies carry the lion's share of the responsibility for caring for particularly young children, that female health workers that had young children might be more likely to be absent. We found it was not the case in 3 of the 4 districts, but it was in Correlates and Jayapura. But the effect was opposite what we thought it might be. Those with children under age 6 were less likely to be absent than those without children under the age of 6. So then you have to contemplate, why might that be? And that was kind of the thing that we wanted our district health partners to discuss and debate in the operational policy barriers. So what would be the operator on, and I guess the other thing is give every health worker a child under the age of 6, right? And they'll be less likely to be absent. Okay, excuse me, wrong button. Sorry about that. Okay, wanting to transfer. Again, this was a variable we thought might be associated with higher level of absenteeism, somewhat related to worker satisfaction. And we found it was not significant, except in Jaya Vijaya, where it was weakly significant, or important rather than significant. But again, opposite what we expected. In Jaya Vijaya, if you wanted to transfer, you were less likely to be absent at the time of the interview. And so again, the question is why. Maybe those who have a free-willing head at the health center who doesn't really monitor absenteeism, they want to stay right here because there's not much accountability. Or it could be those who want to transfer are trying to show that they're good workers and worthy of being transferred. So again, trying to understand why that is might help us to think about whether we want to use this variable. Ethnicity was very sensitive in our policy dialogue sessions. We had several of them, we created 3 categories for this variable. We combined ethnicity with place of birth. So the first category was Asli Papuans, and there were none in our sample that were born outside Papua. So it was Asli Papuan born in Papua, non-Asli Papuans who were born in Papua, and then there would be the people who were not born in Papua, all of which were not Papua. So 3 categories. And surprisingly, it was not significant except in Mamika. And in Mamika, those who were born in Papua, whether native Papuans or non-native Papuans, but as long as they were born in Papua, it carried a 1.5 times greater likelihood of being absent than those who were born outside of Papua and working as a health worker. So again, you wouldn't target ethnicity or place of birth in terms of a cue about who might be more likely at higher risk to be absent any place but Mamika, according to this data. Okay, moving to the environment characteristics. Well, let me just go back, sorry, I want to make one more point about this slide. So if you look at the patterns by the column, you see Mamika, only 1 out of the 7 worker characteristics are significant. So it seems that in Mamika, worker characteristics may not be the best way to go in terms of thinking about how you're going to reduce absenteeism. However, in Correlates and Jayapura, where 3 of the 7 variables is significant, it seems that worker characteristics is a bit more important. And you might have better luck in looking at the characteristics of the health worker in designing an intervention. Okay, moving on to environment. We tested distance or time to the health center as well as fare. The time dimension didn't matter. We tested them independently because they're very highly correlated. FAIR performed much better, but again, only in 2 out of 4. In Kota Jayapura, you wouldn't be surprised, you know, the fares are fairly low to get from the workers' home to the health center. Jayawijaya, Mamika, it was important those with that paid more and would have what we call the not low fare were more likely to be absent than those who paid less. Topographic conditions, here we're basically comparing, so for example, in Kota Jayapura, there are some puskesmas that are located more remotely from the city center. They're a little bit more difficult to get to. I think they're mostly coastal. You have to go by boat. And in Jayawijaya, obviously, the distinction here is more between mountainous puskesmas and mountainous areas and those that are not in the mountainous areas of Pusu or Mina. So curiously, in Kabupaten and Jayapura, that distinction of, you know, whether it was in a more remote place or mountainous or a coastal area, more difficult to get to or not, was not important, but it was important. The more remote, more difficult, more challenging geographic conditions predicted higher absenteeism. We looked at ethnicity, the predominant ethnicity of the community as well. So we categorize this as either predominantly Papuan, predominantly Pendatang, or migrants, and predominant and mixed. And so we can see, interestingly, the category, the composition of the community was important, highly important in all 4 Kabupaten. But again, look at Manchichi. In Kota Jayapura, I think there were no communities that were majority Papuan. They were either majority Pendatang or mixed. And those who were not mixed communities in the catchment area of puskesmas were more likely, health workers were more likely to be absent than in puskesmas that serve the mixed population. Again, what to make of this is the food for the policy dialogue later. In Kabupaten Jayapura, those health workers working in communities that were predominantly migrant communities were much more likely to be absent than people serving in predominantly Papuan communities, and that was the same in the other 3. So Kota Jayapura stands out as a little bit different from the rest. But the rest, absenteeism was lower when the community was mostly Papuan. Number of villages in the catchment area was important in only 2 districts, but the direction was opposite. In Jayawijaya, those health workers working in health centers that covered a large number of villages were more likely to be absent, whereas in Namika, those that covered a small number of villages were more likely to be absent. And again, I'm not sure I understand why that is. Government housing really was not important except in Kabupaten and Jayapura. And as you would expect, those who lived in government housing were less likely to be absent than those that did not. So again, if you look for patterns in this, you might say that you might do better in Jayawijaya and Mamika in targeting environment characteristics as an intervention for addressing absenteeism, less so in Kota Jayapura and Kabupaten and Jayapura, when a couple of those factors were important.
In all districts, is ethnicity of community that's better?
It matters, and as I said in the first one, in Kota Jayapura, and if I remember correctly, there were no majority Papuan catchment areas, puskesmas catchment areas. They were all either majority migrants or mixed. And those that were in, what did they say? Those in the majority migrant communities were health workers were more likely to be absent than in health centers that serve the mixed population. And I guess that's kind of interesting because that would suggest there were, there's a mix of Papuans in those communities. So in each case, so in the other 3, where the community is mostly Papuan, the health workers were less likely to be absent. So So I was curious, in Kotere, for communities that had a mix of Papuans and migrants were less likely to be absent.
In Jayawijaya, mostly Papuans, ethnic Papuans.
Yeah, but there are some communities that are mixed, right? Here, I mean, Wamina is of course fairly mixed. I think that one, the health centers that serve the immediate Wamina area would be mostly mixed. But again, this is regression, so it should take account of any other correlations, and you should be getting, if the regression is done right, a clean effect of this variable controlling for other things. Yes, I do.
Well, actually, you measure ethnicity of community. When do you say mix? Is it 60% Papua, 40% non-Papua, or actually 70-30?
Yeah, I'll have to go back to our notes to get that detail for you if you'd like it. But I believe we collected that information as part of the qualitative interviews with the key informant, the leaders of the community, and I think it's mostly the community leaders where we asked that question. So there's some subjectivity in this, more than likely. I don't think there was a clean break. We didn't have a census where we had the ethnicity of each Kashmir, and I think that data probably would be very difficult to come by. So, yes.
Just wondering whether you also measuring about the security in the environment.
Very good question. In fact, in worker satisfaction, we included security, feelings of safety in the community and in getting to and from the health center. So we measured the care. The only thing we measured that's security related in the community was in the health facility assessment, the condition of the health facility, where we did measure physical security of the compound itself. And so that's, in terms of other analyses we could do on this data, that's one we could take a closer look at. We did not decompose, we created a scale for the health facility condition, and we also created a scale for the health workers' satisfaction. And we didn't decompose them for this analysis, but we could take a closer look at them later. My sense is that health workers very rarely raise it as a major concern. Curiously, the communities actually, when we ask them why health workers are absent, they raise this more commonly. They said, health workers, are afraid of coming to the area. They're afraid of conflict. Obviously, that was more the case in Jayawijaya and Mika and in the other two districts. So we also have a really interesting analysis to compare community perceptions of absenteeism and the reasons for it. We actually did that in the report that survey leaders submitted. We have some information about differences between communities' perceptions of absenteeism and the reasons, and what the health workers state. Keeping in mind that actually, and that's another interesting finding, in communities that we have this, that we're jumping to the conclusion right now. Communities seem to be more in tune with the results of the logistic regression than the workers. Workers will always tell you, I'm not saying sake, they'll tell you a reason that is not necessarily the real reason. The real reason, if you look at it, is they don't want to spend that much money, they don't want to spend that much time. The condition of the facility is poor, and things of that nature. The health, the community is kind of zeroed in on those real reasons. Okay, is that yes, okay? So let's move on to the last set of characteristics, the health center characteristics. I'm just going to flash up there's two slides here. These ones are more related to personnel and the health center head. You can see there aren't a lot of them that are significant. All of the interesting issues are here in this slide. So number of health facilities is important in 2 out of the 4. Again, the direction of the influence was pretty much the same. So those that are serving a low number, that have a small number of health facilities, were more likely to be absent than those that are working with a lower number of Those that were BONET facilities, emergency obstetric care capable, that was important in 3 of the 4, and the direction was different in Kota Jayapura. Those that were not BONET were more workers in health facilities that were not BONET were more likely to be absent than those in BONET facilities. The opposite was true in Jaya and Mamika, where those who were at a BONET facility were more likely to be absent than not. Again, perhaps it's because those that are BONET facilities in more rural districts may be called more often to go outside the district, or maybe they have to deliver a baby in the middle of the night. That's something that you have to get the perspective of the district health officers who should know better about that. Whereas in Kota Jayapura, there might not be as much of the middle of the night, there might be other places where women deliver. Having overnight bed capacity was again important in 2 of the 4, and having no overnight bed capacity was associated with higher absenteeism than those that had overnight bed capacity. Being open 7 days a week versus less was predictive of higher absenteeism as well. So those that are working in facilities that are open 7 days a week were more likely to be absent. Again, could be because scheduling is more complex and perhaps a little less regular and tiring. The health center condition was another cross-cutting variable that mattered everywhere, but it was sort of a difference. Kota Jayapura and Kabupaten Jayapura, those working in facilities assessed that had a low score on health facility condition were more likely to be absent than those that scored high. Health facility condition included the physical facility, the condition of it, maintenance, broken windows, lights that were missing. It included utilities, water, electricity, and how well they were functioning at all. It included presence of tracer equipment and drugs. I included an assessment of whether the drugs that were in stock were actually expired or not expired, and what else? It did include a couple of security questions, whether the facility was lockable and whatnot, and also I think cleanliness of the facility. So as you expect, those facilities that were in poorer condition, health workers were more likely to be absent. The opposite was true in Jaya and Mamika. Those that were in poorer, actually no, Jaya is similar to the other 2. Mamika, for some reason, health workers were more likely to be absent if they were working at a facility that had a high health facility condition score. Again, something to look at. Maybe they're more motivated because they felt a stronger passion to serve the community where the health facility was poor. I don't know. That's something to take a look at. Obviously, you would expect internet connectivity to not be an issue anywhere where none of the health centers had internet connectivity. You could only assess it in Kota Jayapura. Having internet connectivity was associated with lower absenteeism in Kota Jayapura. And that's a working internet connectivity. Mobile phone signal was relevant in all 4, and in 2 of the 4 districts it was important, the other 2 not. And again, the stronger the signal, the less likely the health workers were to be absent. Finally, this has a slide. Curiously, the health center head was not so important. Some of these characteristics were not as important as they thought they would be, but the profession was important differently in different places. And again, I think in 2 of these districts, there were no doctors, as was Kesmas head. But in, let's see what I did here. Kota Jayapura, those health centers that were led by a non-doctor, nurse, or midwife, they were usually a public health professional, the workers were more likely to be absent than in those that were led by a nurse or a midwife. There were no doctors or health centers in Kota Jayapura, if I remember correctly. in Kabupaten Jayapura, if the health center was run by a nurse, health workers were more likely to be absent than if they were run by a midwife. Again, there are no doctors running health centers in Kabupaten Jayapura, if I remember correctly. And in Jaya, those that are run by midwives have a higher likelihood of the workers being absent than those that are being led by other kinds of health workers.
Did you see the technique of the cat on this as well?
We have that data. It would be interesting. We didn't include it in this analysis, but that would be something we could add in. Take a look at that. We do have that, right? Okay. Interestingly, whether the head was absent or not absent, we thought that might help to predict absenteeism. It did only include the Jaipur, but guess what? When the health center head was absent, the health worker was less likely to be absent. So, explain that. Oh, well, this is, we'd love to have some resources to look more deeply at some of these issues. But again, not all of these came out in the policy barriers, operational policy barriers dialogue workshop, because they went where the district health leaders wanted to go. So they didn't obviously have time to look at every one of these. So we could design some additional sessions if we wanted to look specifically at the drivers of some of these things. And finally, we thought that having a doctor, lab tech, or a pharmacist might be important, but the only place it showed up as important was in Jaya, where if they had no lab tech, absenteeism was higher. Part of this is because, a relatively small number of SKESMAS in each district. I think most of them probably have no pharmacist. And so that went in, what we found is that people usually very easily compensated for the lack of a pharmacist. They just assigned a nurse or a midwife to take care of that function of dispensing the medicine. A little bit more difficult to compensate for not having a lab tech. I have a little interesting story. Looking at one of the health facilities, we went into the lab, we looked around, it was really filthy, and there was nothing in there. And so we said, okay, we went on our list, do you have this, do you have that, do you have a microscope? Well, yes, we have a microscope. We go, well, we're looking at the room right now, there's no cabinets, and there's no microscope. I have a microscope, and they said, the lab technician took it home. So I was thinking, okay, that's really helpful. And the last AHO supervision visit, on bivariate analysis, it looked like it was going to be important. Those that had a more recent visit were more likely to be absent. But yeah, well, and that might make sense. They wouldn't expect another DHO visit for a long time. So, it could loosen up a little bit. Well, in the multivariate, it shows up as not significant. So you have to be a little careful in using the bivariate results. That was one of the lessons. Okay, so how did we use the findings? I'm just going to run through these very quickly. This was a very complex set of policy dialogue sessions. This operational policy barriers chart here was produced. It's a bit old now, 2001, but this is when some of you in the room may remember the Global USAID Policy Project. It was mostly focused on reproductive health and HIV/AIDS. And when that project was in the process of transitioning from focusing on more macro national level policies to operational level policies that guide, the facility itself or at the district level, more local policies, things such as opening hours, things that the health facility may have some, well, actually in this case, it's maybe an informal policy, but the fact is, Wayan said that facilities were open at 8, but they didn't really require the workers to come in much before 9, and the fact that they're supposed to be open until whatever, 2 o'clock in the afternoon or so. I remember one health center we were visiting for the survey, and literally the people were crowded at the door at 11 o'clock, because that's when the SKESMAS had let them leave. So that's an operational policy. It's a policy that's set by the facility itself, and something that you could perhaps influence. So you look at the environment, and you can see reflected in our framework most of these items here in one way or another. So what you do with the policy barriers analysis is you look at, so for example, these factors, what appears to be significant in terms of describing an absenteeism, and then you identify through dialogue what the operational policy barriers might be that are contributing to the absenteeism to that particular reason. So for example, housing, absenteeism is lower, and so why is it not playing out in other districts? Because there isn't enough housing, the condition of the housing may not be good. You look at, and then you look beyond that, you say, well, the condition of the housing isn't good, it's not sufficient because there's not money to build it or to maintain it. So those are operational level policy barriers that can be addressed locally. So they identify factors that they want to address, they think that are most important, have the biggest possibility of having an impact on absenteeism, and then they vet those possible solutions through their own relatively subjective analysis of feasibility. Politically feasible, will the district, will the Bupati agree to this? Will they sign, for changing a policy? Will the health workers buy into this? Then they look at monetary feasibility, financial feasibility. How much will it cost to implement this? So housing, we need to build more housing. Okay, fine, but how much is that going to cost? What's the likelihood that we're going to be able to get the money that we need? Et cetera, et cetera. And then so it's financial, managerial, and political. Managerial was, what do we have to do as a district health office in order to supervise the implementation of this? Do we have the resources to supervise this? So they create scores for each of the interventions, and each district comes out in a little bit different place. So we just wanted to share with you a few of the differences across districts. We haven't listed the districts here. So poor job performance of the health center, that's how some of the districts define health center head characteristics, and fair assessment of the driver. In some places they said they wanted to address it from a perspective of the lack of fair performance standards, some from a leadership capacity angle, and some from rewards and sanctions angle. And so the operational policy solution is appropriately different based on the barrier they think is contributing to the poor performance of the health center head. Likewise, high fare for health workers to get to their health center. In Jaya Wijaya, I think this one was Jaya Wijaya, they felt that everybody got the same subsidy for transportation. It wasn't very well targeted. Those that needed it more did not get more. Those that didn't need it didn't get it. And the interesting thing here was that it seemed that, as I understand it, the subsidy was put right in their monthly paycheck. It was not, so it wasn't even identifiable as a transportation subsidy. It's actually one of the things that health workers in Jaya Wijaya said was, give us a transportation subsidy for the fares. And when we shared that with the district health officials in Jaya Wijaya, they said, what are you talking about? We already gave them a subsidy. Well, they're not really, they don't see it. Okay, health workers are not living in assigned housing. This was the factor that was addressed by Kabupaten, Jayapura, and so they basically issued a regulation that requires them to live in their housing, and at least their intention was to be more vigilant about monitoring that. And finally, DHO provided transportation. I think this was also Kabupaten, Jayapura. The transportation to some of the more remote health centers was available, but guess what? The vehicle was managed by the district health office and not always available when the health workers needed to get back and forth to their health center. So the idea there was to transfer management of that vehicle to the Puskesmas that it was intended to serve instead of the district health office. Finally, a final illustrative issue was the poor health facility condition. In one of the districts, the defined it as the barriers being fully coordinated planning, and another import guidance and support from the district health office. In the planning issue, they wanted to develop, they wanted to focus on the drug supply issue of making sure that the health center received its drugs in a timely fashion. And in the other district, they issued a formal decree to establish a team from must integrate it with the monitoring and evaluation team and to evaluate it regularly. Okay, some observations and implications. Well, I think many of these Wayan has already covered. Time of day greatly affect the rates. If anything, our methods, we chose 9:30 to 10:30 because, again, as Wayan said, if we measured it earlier or later, it was almost, it doesn't tell much of a story when almost everybody's absent. But also we need a consistency across each discussing, measuring it in different times at different places, but again, a skewed picture. You need to verify those who are claimed to be working at sub-facilities. That's kind of related to this issue. The heads of the health centers don't always want to admit that a lot of people are absent. And, we did discover 50 health workers that some of them were the health center and said, yeah, you're here today. When you went out to the floor, I remember one of the pilots, we went in and the health center had said, okay, he gave us, the rundown, who's there, who's not. We said, can we go out and now sort of just see them? And he looked at Danny actually, and he wasn't very happy. So he walked out of the room. I was sitting in the room there quietly. He walked out of the room. 30 seconds later, Danny came and said, he told me he doesn't have time for this. So he said, okay, ask him. Oh no, the first thing was, they're all busy, you can't interrupt them. I said, well, tell them we don't need to interrupt anyone, we just need to cite and verify the people. So they went back out, 30 seconds later came back, and he said he doesn't have time. Then we went back and said, okay, they've already closed the locket. It was like 11 o'clock, I think. They'd already closed the locket, the registration locket. So I said, the staff is sitting there, not doing anything. Ask if that person can walk you around. And so I think the head of the health center was a bit frustrated because we found we couldn't say no to that. And so we walked around and we found that there were 6 nurses who were in fact not there. And that's when, oh yeah, they're all at Suriastini. So when we went and we interviewed them, we didn't tell them that what the health center head had said. We just said, you weren't there, can you tell us why? And half of them basically said, I was sick, or my child was sick, or they admitted that they were not at a close encounter. So it's really important to not take at face value and to verify what you're seeing, both by walking around and going to people that were said to be someone else. This issue, perspective on meetings, trainings, and seminars, really matters. It depends whether you call it a lot or not. The absenteeism rate would have been 5% lower in most, on average, in the districts if we allowed the excuse of meetings, trainings, and seminars. But we decided to count them as absent because it really, there's a lot of that goes on, and I'm sure it's the same with teachers. It really, really detracts from the service delivery capacity. And not that those seminars, trainings, and meetings aren't valid, they're happening, but I think people often look for lots of opportunities. This is nothing new to anybody in this room. So how you handle them matters also in what the rate is. How to count long-term absent providers. As Wayan suggested, the first thing we did, we walked in and said, is this health worker still here? Yes, no. If they're here, are they scheduled to be working now? Yes or no? Well, in one of the health centers, I remember, there was a nurse who hadn't been there for 4 months. And so if you ask, are they scheduled to be working now? The answer is no. They didn't count them anymore. But she should be counted as an absent provider because the reason she's not included in the schedule is because she's never included anymore. You just don't. Funny thing is that the first day we came to that health center, the health center was closed, so everybody was absent. Second day, what we did in those cases, the Wayan said, we told the community, okay, we're coming back. And we didn't tell them what day. And of course, the word then goes out to everybody that works at that health center, and most of them are reachable. And the day we came back to the health center 2 days later to go by boat from one of the coastal towns. And we got to the health center about half an hour, 45 minutes. The nurse comes charging up. This is the one that was absent for 4 months. Somebody from the coastal town ran to her house and said, coming back. And we asked her, we said, oh yeah, I'm absent once a week because, a market day is a difficult day to book in this direction. So you have to really think about, how to identify those long-term absent providers and whether they're being counted as scheduled or not scheduled by the Puskesmas head. Special arrangements, there were some health centers, one in particular I remember in Kabupaten and Jayapura where it was remote. There were 8 health workers assigned to that, doctors, nurses, and midwives to that health facility. Well, I think when we went there, only 4 were there. So they told us, well, we have an arrangement here. It's not so formally blessed, it's informally blessed by the district health office, where they would rotate. 4 would go in for 3 months, and other 4 wouldn't. Who knows where they really are, and those other 4, and then they switch. So do you count them as absent or not absent? In this case, we counted them as not absent because it was an informal agreement, and so whether that's right or not made some difference too. And finally, as Wayan said, this was really quite amazing, the discrepancy between the rosters for the health workers at the Puskesmas. We had a consultant go in before the study, collect all the rosters for each Puskesmas by the consultant. The consultant collected them. That was the base that we approached each health center with. Only half of the people on average on that list were actually at the health center. The other half, some of them had transferred out, and they all told us they had their SK, they had their formal approval to be transferred to another health center. Somehow that never got entered in the district health office list. And there were a large number of other workers who were formally and officially at that health center, posted at that health center, that weren't on the district health office list too. So you really have to take great care in confirming the roster, which creates your denominator for absenteeism. Okay, observations. These rates were not a surprise, even in Kabupaten and Jayapura. Oh, sorry, okay.
I'm interested in this special arrangement. Is that political arrangement? Because, the Papua is special case. Some of the centers raised because of the relationship with the head of history or China.
One area in Mimika, Papa, we have also similar like in Kabupaten Jayapura. So it's not every 3 months, but every day, in 1 week. So they in one Puskesmas they if one person, they have an arrangement that several people only we will go to the health center maybe Monday, Wednesday, and Friday. Something. The other health worker will just present in the health center during Tuesday and Thursday, or something like that. So this arrangement actually, according to them, is already blessed by the Dinas Kabupaten Kota of Mimika. They know, but actually, what happened? They have they still absent in the city, in Timika city, but actually they're not present in the Puskesmas because the distance is about 45 minutes from Timika city to the health center. So they actually in the absent form they listed as present. All of that it's like 15 health worker, but actually only 7 of them present every day. So according to, because of this kind of the arrangement, for example, arrangement, so we counted as the in the how analysis is present, that what do you call it, that people is present, that hard worker is present. So answering your question whether is this political or some special arrangement, it's hard to answer whether this is part of their dinas policy or we planning to during the policy dialogue is that they said that they aware about their condition actually, and that special the two buckets must be mentioned about it. But yet you have another suggestion?
Yeah, I agree. It's kind of very difficult to know what's political, who's used the connection to get approval for those special arrangements. The one that I'm more familiar with and less familiar with the Monica group in Kawakasan for the One Health Center. You know, it's unlikely to have been political so much because it was 4 and 4, and it was a rotation. Seemed to be more expedient given the logistics of the location than political. But you know, we have to probably do more in-depth interviews in order to determine. Okay. So again, as I said, even in Kabupaten Jayapura, he was not surprised. I was really kind of interesting. Well, the guy, the head of the HR, the district health office, human resources division, is kind of a very easygoing guy to begin with. So maybe he didn't look surprised because he just nothing surprises him. But
For all districts like that.
well, this one in particular, actually, yes, all of the districts. Jaya Vijaya and Amika, they were not surprised. They were not surprised. In fact, they seemed to welcome the confirmation. The guy, the HR head in Kabupaten Jayapura actually, you know, claims that I've been looking for them, so I could justify doing something about it. When it's just anecdotal, you know, people don't want to listen. With evidence, he was able to be more vocal about it. As we've already talked about.
If you only have 1 more minute.
Sure, just about that. The second one we've already covered, the underestimate problem. We already talked about communities having good instincts and an opportunity there to perhaps involve communities more in abatement of absenteeism. The issue of whether a reason for absenteeism is acceptable or unacceptable is really quite contentious. So, you know, health workers don't have very good guidance on what's acceptable as a reason and what's not. And even the district health people had great debates about what was acceptable and what was not. So, a natural disaster was a good reason, in their opinion, for not going to the health center. Well, what do you do with all the injured people in a natural disaster if you're allowed not to go to work? So, you know, there's some room there for work. And then we talked about the operational policy various dialogues, so I won't go into that again. Future research, we wanted to leave you with this. Clearly there's area for evaluation of the interventions that each of the districts decided they wanted to implement as a consequence of looking at this data. There's a very rich set of additional questions that we could answer using the data set that we have. We intentionally collected a lot more data than we thought we would use in this particular analysis. And then clearly, I think the last national picture of health worker absenteeism is quite dated, and it's certainly not nearly as in-depth as this study was. It would be very useful to get a broader perspective, particularly in light of the fact that there are clear differences by location in these issues. So, and finally, just leave you with one of the pilot districts, beautiful little place. This was the place I mentioned earlier that was closed. 100% absenteeism when we went on pilot. The community is so clean, so well organized, and the people there in the focus groups were painfully aware of their rights to have health workers present. And were kind of, they just didn't know how to go about insisting on their rights. The health center is closed as much as it's open in this particular place. It was very poignant talking to the communities to hear their frustration. And we hear the frustration of the midwife who is Papuan from this particular desa, who is carrying the load. She opens a health center to get drugs 24 hours a day when she needs to. Everybody relies on her, while the doctors and nurses largely don't show up. And there is counseling here, by the way. So I leave you with that thought and look forward to discussion. Sorry, we're going over time.